Let's talk about changes that occur during pregnancy. There are lots of changes that occur in pretty much every organ system in the body when pregnancy occurs. So some signs of pregnancy are Chadwick's sign, which is when the cervix and the vaginal mucosa change color. And this would be seen if you did a speculum exam. It turns to a bluish purple coloration. The cervix softens, which is called Goodell's sign. And the lower segment of the uterus is called Hagar's sign when it softens as well. So we're going through like some of these terms that you may see. You'll probably see these in your F.A. Davis book or in your ATI book. But it's important to become familiar with them. You also need to become familiar with presumptive signs of pregnancy, probable signs of pregnancy, and positive signs of pregnancy. NCLEX likes to ask these questions. Exams about OB like to ask these questions. So your subjective signs of pregnancy are the fatigue, being really tired, the changes that occur in the breasts, they become enlarged and they become tender, mostly in the first trimester. Patients also complain of nausea and vomiting, and this is usually due to HCG or human chorionic gonadotropin, which is a hormone that is produced when a woman is pregnant. Amenorrhea is when you have absence of menses. Women also oftentimes will have to urinate more frequently. Their skin color will change. They get a little darker, a little more hyperpigmentation in their face, which we call melasma or chloasma. You may also see that in their abdomen. Quickening is another presumptive sign of pregnancy, which is when you feel the first movements of the fetus, or you think are the first movements of the fetus, but they're presumptive because nothing is positive until you see a provider and the provider can verify that there's fetal movement or heartbeat or anything like that. Another presumptive sign would be if the woman's abdomen is getting larger, so the uterus is getting larger. Your probable signs are going to be feeling Braxton Hicks, which are like practice contractions. They're not real contractions because real contractions would cause cervical change and then you would deliver the baby, but Braxton Hicks is when your body is practicing. So you feel these contractions, but they're not changing your cervix for delivery or birth. Another probable sign would be having a positive pregnancy test. So your pregnancy test, whether it's a urine or a blood test, is going to detect your HCG, your levels of human chorionic gonadotropin. Another probable sign would be measuring your abdominal enlargement. And then ballottement is when we do a cervical exam, and when we put our fingers into the cervix, we feel the presenting part on the cervix, and if we push it up, it actually floats and then it comes back down onto the cervix. So that is called ballottement, when it floats, the presenting part floats and comes back down. And I already went over Goodell's sign, Chadwick's sign, and Hagar's sign. So those would be probable signs of pregnancy. Excuse me. And your positive signs of pregnancy are going to be when you actually see a provider and there's an ultrasound and they can verify that they see an embryo or a fetus with a picture. There's also fetal movement that's detected by a clinician at 20 weeks, or you can hear a fetal heart rate with a Doppler or an ultrasound. So the pregnancy test, like I said, picks up human chorionic gonadotropin, or HCG. It can be present in urine, and that can make you have a positive pregnancy test, which would be reliable between 14 and 21 days after conception. And they're pretty good at being accurate. Your blood serum levels of HCG is a quantification, so it's a quantitative number of the hormone in your blood, and it is reliable after 4 days after there has been implantation in the uterus, and it is pretty accurate. So the uterus, when it's pregnant, if this isn't obvious, increases in the size. It gets heavier, it gets longer, wider, because it has to adapt to a growing fetus. And then the musculature, because your uterus is actually a large muscle, it gets bigger. So you have hyperplasia, more muscular tissue, and hypertrophy, so the muscle gets thicker. And you tend to, because the uterus is growing, this muscle is growing, the reaction of the uterus is to kind of contract, right? So that's where you get these Braxton Hicks to come from, and they're usually originated from estrogen. They're not regular contractions, where like they're not coming every 2 to 3 minutes. They're just very sporadic, and they're usually painless. They're kind of annoying. You know that they're there, but they are not causing you distress. The uterus, as it starts to grow, because it's all the way down into the pelvis, after about the 3rd month, it is actually has moved up into the abdomen because the fetus has grown. By 20 weeks, your uterus should be at the umbilicus, which would be about 20 centimeters. So if we measured with a measuring tape from the top of the pubic bone to the top of the fundus, it would be 20 centimeters, or about 20 centimeters. So this can be pretty reliable in telling you how many weeks gestation the patient is, unless there is, or you may suspect that something is wrong, like maybe the baby's really small, and it could be because mom has some type of condition that is causing the baby to measure smaller. And we'll talk about that later in the class. Or the baby could be larger than what you would expect, so your centimeters are going to be off and be larger than what you would have expected to measure. So we talked about the cervix with Goodell's sign and its softening. So you produce a lot of estrogen when you're pregnant, and your body produces something called a mucus plug. And that mucus plug is made from the estrogen, and it builds basically like a really big, thick, white mucus substance that covers the cervix. And it's meant to protect so that essentially nothing gets in there, no bacteria or viruses or anything like that. And then we talked about Chadwick's sign, and the cervix tends to get soft. This is what ripening is, about 4 weeks before the delivery, before the body is ready to give birth. And that's also how we kind of can assess whether a patient is ready to be induced or to deliver their baby. The vagina has increased vascularity and elasticity. It is also thickened. The vaginal vault actually lengthens. There's more secretion, so a patient may complain or describe having more discharge than normal, which we call leukorrhea. It's usually like a white, thick discharge, so they'll just complain of having increased secretions. I would recommend that they wear like cotton underwear, maybe a panty liner, and then if there's an odor or there's itching or the color changes, then I would definitely recommend that they see a provider. So the ovaries are going to get bigger up until the 12th or the 14th week of gestation. You also have cessation of ovulation. So the egg has already been fertilized, has been implanted, so there's no more ovulation. You're not going to be spitting out any more eggs. There's not going to be any more menses. Those breast changes that we talked about, the tenderness, the heaviness, the enlargement, it's because the body is getting prepared for lactation. So we talked about the changes in color, pigmentation of the skin. Well, one of the things that occurs is that the areola is going to get darker. The nipple size also gets bigger, more erect, and your body also starts to produce something called colostrum, which is like a clear, thick, sticky pre-milk, if you will. It's can be expressed after the 12th week, but it is full of nutrients, antibodies, and good things for the baby, calories for the baby in the first couple of days of life. So this picture is a really good depiction of what happens during pregnancy. As you can see, the fetus has grown, and so it tends to make its own room. The organs are displaced, so you can see the stomach is little squished up there. The liver is pushed up, the bladder is compressed, and so it can make things a little uncomfortable for mom because it's such a tight space for the baby to be in. So things that occur with pregnant women as far as their GI tract is that their gums become swollen. And when this says friable, that means that they can bleed very easily. And then botulism is basically that they salivate a lot. And pregnant women tend to have more problems with their dental dentition during pregnancy. Also, because the baby has grown and has pushed the gastrointestines out of the way, it slows peristalsis, so therefore it's harder for food to get through, and so it causes heartburn, it can cause nausea and vomiting, it can cause constipation, which can also lead to hemorrhoids. The fetus is very heavy, so it's pushing down on the GI tract there, and you tend to have just more GI issues because this fetus is taking up more space. Also, everything kind of shifts up. So as far as cardiovascular is concerned, the heart actually moves. It moves up and over to the left. So if you were to code a pregnant woman, you would want to adjust your hand placement for your chest compressions. They also have an increase in their blood volume. It goes up about 50%, their pre-pregnancy level. which means that their cardiac output has to increase as well, and this increases their venous return. So their heart rate is going to increase as well. But they need this because there is another life that needs to receive oxygen and blood and nutrients, and so all that extra needs to compensate and go to the uterus. There is a little bit of a decline in the blood pressure until mid-pregnancy, and then it returns to pre-pregnancy levels. But you'll notice that when you're looking at the labs that there are going to be a larger number of red blood cells as opposed to like the plasma volume. And what happens is you're going to see what we call physiologic anemia, and that is basically it's not a real anemia because plasma is the watery portion of the blood, so it dilutes the red blood cells and it makes it look less than what it really is. There's also an increase for iron. They produce more fibrinogen and plasma fibrinogen, which basically are your clotting factors. So pregnancy is considered a hypercoagulable state. Pregnant women tend to produce blood clots, which is why they're at higher risk for deep vein thromboses. In addition to your cardiovascular, I want you to take note, this is very important, that the uterus is very heavy. And so as you can see in picture A, the woman is lying on her side, which is what we would prefer. And the reason is because if you look at picture B, where the mom or the woman is flat on her back, the aorta and the vena cava are compressed completely. So that's going to cause something called supine hypotension. So the weight of the fetus and the uterus on those vessels is going to inhibit the flow of blood, which is going to cause this low blood pressure in mom, which thus is going to affect baby. So anything that happens to mom is going to affect baby. So what we would prefer is that mom is either on her side or she's on a tilt when she's at home, when she's in the hospital, wherever we would recommend, hey, just, lie on your side so that those vessels can stay open, as you can see in the other pictures, so that baby can get the blood and oxygen and nutrients that is needed. But when supine hypotension occurs, the patient is going to describe feeling lightheaded and dizzy. And like I said, whatever happens to mom happens to baby. As far as respiratory is concerned, again, your woman is going to be short of breath because your lungs are going to be like displaced a little bit. They're going to be pushed up. The diaphragm is also going to be pushed up because this fetus is growing. So it's going to decrease the ability of the chest wall to expand, and the amount of air that is able to be brought into the lungs is going to be decreased. The ironic thing is that there is increase in oxygen consumption, so their respiratory rate is going to be increased, but they definitely do complain of shortness of breath. The other thing is that they tend to have like congestion in their nares because there's increased vascularity there, and they do suffer from nosebleeds. Additionally, in the renal system, there's a dilation of the renal pelvis and the increase in curves of the ureter. So you're going to have increased glomerular filtration, which is going to produce more urine, and so they're going to urinate more. With increase in kidney activity, the pregnant woman lying down, the greater increase in later pregnancy lying on their side. So in the beginning, they definitely have in that first trimester more urinary frequency. And the reason is because, remember, the uterus is down in the pelvis, right? So it's very close to the bladder. And so there's increased urination. And then as the uterus grows, it goes up into the abdomen. So in that second trimester, they don't really have to urinate as much. So the first trimester urinary frequency is normal. In the second trimester, if the patient complains of urinary frequency, that's a bit abnormal, and I would question whether the patient has a urinary tract infection. Now, if we're getting to the third trimester and we notice that the baby kind of drops, then I might expect a little bit more urinary frequency. But in the second trimester, I would question if mom has a urinary tract infection. As far as musculoskeletal is concerned, there's softening and stretching of the ligaments and around like the hip joint, the pubic symphysis. So patients will complain of something called round ligament pain around their sides. These ligaments are being stretched and they can be a bit uncomfortable. They also have something called sway back or upper spine extension. So if you've ever seen a pregnant woman waddle when they walk, that's what this is. Their center of gravity is off because they have a big belly, right? So they have to adjust for that center of gravity. And another name for that sway back is called lordosis. And their abdominal muscle wall can weaken. So what you can have is where the abdominal wall muscle can split, and that's called the rectus abdominis, and it does not grow back together. I mean, they can work out as much as they want to try and strengthen those muscles, but they will never grow back together. They're always going to be separated. And that doesn't happen to all women, but for some women it does. So as far as the skin is concerned, like I said, the hyperpigmentation is melasma or chloasma. You may see it as both names. Pregnant women do get a dark line down the center of their abdomen, and that is called the linea nigra. They also get stretch marks, which tend to turn like a silvery color. Those are called striae gravidarum. And they tend to also get varicosities. So because there's so much weight and so much pressure in the pelvis, you will see these varicosities on the labia. They're like bulging veins on the labia. They also may get vascular spider veins on their upper thighs, and it's just because there's so much weight there. They may complain of palmar erythema, where their hands turn red, they get very itchy, so that's another just annoyance. And their hair tends to grow really long, very fast. Their nails grow very long and very fast. The thyroid gets a little bit larger. It increases metabolic activity because the basal metabolic rate goes up, and there is a decrease in the thyroid stimulating hormone, your growth hormone, and then your follicle stimulating hormone actually stops, and so does your luteinizing hormone, because those are, not pregnancy, but reproductive hormones. They increase you increase in prolactin, which is a hormone that helps you produce milk. So your body's getting ready to produce breast milk. And there's also a gradual increase in the oxytocin with fetal maturity. And that's because you need the oxytocin to cause uterine contractions so that you can go into labor and have the baby. There's also, for some women, what we call an increase in insulin resistance, and that is caused by a hormone called HPL, or human placental lactogen. Human placental lactogen is produced by the placenta, and it causes this insulin resistance, which is how you end up with patients that have gestational diabetes. So that's very important for you to know. We'll talk about that more later, but you will need to know that. Your adrenal glands will increase in producing cortisol and aldosterone, and you're going to produce, pregnant women are going to produce more prostaglandin. You also obviously are producing estrogen and progesterone. Those are the pregnancy hormones. That's what's really maintaining the pregnancy. So if those hormones, that progesterone and those estrogen levels drop off, you're either going to go into labor if it's time, or if it's not time and it's too soon, you're going to go into preterm labor and have either a preterm delivery or you're going to have a miscarriage. The umbilical cord is formed from the amnion, and it is basically what is delivering oxygen, blood, nutrients from the mother through the placenta to the fetus or the growing embryo. And what you need to know is that there is one large vein and two small arteries. So the acronym that you should remember is AVA, artery, vein, artery. The white gelatinous stuff that surrounds the artery, vein, and artery is called Wharton's jelly, and it's very thick. It's very protective. It prevents, well, it's meant to protect from trauma, from compression, and things like that. It does go through quite a bit in utero. The amniotic fluid that is produced is actually produced from, some of it comes from the placenta, and then other parts of it comes from fetal urine. So yes, amniotic fluid is made from fetal urine and some of it from the placenta, and it helps to keep the temperature constant and warm for the fetus. It helps with growth, allowing room in the uterus for the baby to grow and develop. It also provides protection from trauma. It's like a cushion, so the baby can float around in there. It allows the umbilical cord to be kind of however it wants to be, instead of being restricted or compressed or anything like that. And it allows the fetus to move around freely in utero so that the baby can develop normally. So your pregnancy in trimesters, if we're looking at it in trimesters, is the first trimester is going to be conception through 12 weeks of gestation. And then your second trimester is going to be 13 weeks to 28 weeks gestation. The third trimester is going to be 29 weeks to 42 weeks gestation. So a term delivery or term gestation is anything that is 37 and 0 weeks. So if somebody was 36 and 7, they're still preterm. So the 36 and 7 means 36 and 7 days. So if the person is 37 weeks and 0 days, they are term. And anything above that, so 37 and 1, 37 and 2, 37 and 3, that is all term. But if they're anything less than 37 and 0, 36 and 7, 36 and 8, 36, 7, they're preterm. So how do we take care of patients that are pregnant? Well, first of all, the nausea and vomiting is going to be a big deal, so that's something that you would want to address. I usually talk about having morning sickness, but morning sickness doesn't necessarily happen only in the morning. It can happen any time of the day, and it's usually related to these elevated human chorionic gonadotropin or HCG levels. At least that's what science and research has told us. They're not exactly certain, but they think that's what it is. There have been alternative treatments like acupressure. The big thing is ginger. So anything with ginger, it could be ginger tea, ginger candy, ginger ale, anything like that often helps with the nausea and vomiting. Or antiemetics like Zofran, that's a really big one that they like to give to stop the nausea and vomiting. So that's the ondansetron. Metoclopramide, which is Reglan, and then over-the-counter antihistamines also help. So like Benadryl, things like that would help. There's not many medications that pregnant women can take because they can cause fetal malformations, and so they're very limited on the drugs that they can receive. Another common complaint is that urinary frequency, like I said, is pretty normal early in that first trimester to have urinary frequency, but in the second trimester or anytime if they're complaining of pain, burning on urination, or there's blood in the urine, then they should be tested for a urinary tract infection. A urinary tract infection anytime in pregnancy can cause preterm labor and preterm delivery. We want to encourage them to drink plenty of water, plenty of water. So at least 2 liters or more, and to keep their bladder empty if they can. In the summer months, pregnant women tend to not drink as much as they should. They think they're drinking enough, but they are not. And a dry uterus is not a happy uterus. It's going to contract. Another thing would be the backache. So they have that exaggerated lumbar sacral curve with the uterus because it's getting larger and the weight and the center of gravity is off. So you want to encourage them to use proper posture and mechanics, body mechanics, and bend at their knees, not at their waist. And to widen their stance so that they can keep their balance. You can also talk to them about round ligament pain. Carpal tunnel syndrome is also an annoyance of pregnancy because the fluid, it tends to push on the carpal tunnel nerve. But braces on both hands or the affected hand can help. You want to assess for intimate partner violence, and you want to do a psychological assessment. So when caring for a pregnant woman, we're doing fetal assessments and screening. So we may do like a Doppler to get a fetal heart rate, or we may need to do a fetal monitor to get a heart rate. The fetal monitor can also detect contractions, but our hands also work as well. So we can feel an abdomen and palpate for contractions and fetal movement. There's quite a few screenings and tests that we do. We want to do any type of assessments for risk factors, like do they have a risk factor for high blood pressure or preeclampsia or diabetes? What comorbidities did they have before they came into the pregnancy? Because some people come in with insulin-dependent diabetes or lupus or something like that, and so that needs to be managed so that the pregnancy can go on as normal and closely watched. A big thing here that you want to look at is the prenatal care for the first appointment. This is when you get all the biographic information. So we're asking about her health history, her medical history, all of her vaccines, what her obstetric history was, how many times she's been pregnant, how many times she's delivered, how many babies were term, how many were preterm, has she had any miscarriages, has she had any induced abortions, anything like that we want to know. We want to know what her family history was. Has anybody had cancer? Does anybody in your family have any chromosomal abnormalities, Down syndrome, Huntington's, anything like that? We're asking those questions. We want to know where she works, because maybe the environment that she works in could expose her to toxins or teratogens, which would cause fetal malformations. We need to know what medicines she's on. What does she take that's over the counter? What does she take that's prescribed? Does she take any supplements? Because any of those things could also cause teratogens, which cause fetal malformations. So it's a big appointment. That first prenatal appointment is a big appointment. We also want to ask their social history, as far as, do you smoke? Do you use chewing tobacco? Do you drink alcohol? Are you using any illicit drugs or street drugs? And you also have to specifically say, are you using marijuana? Because nowadays, because marijuana has been legalized in so many areas, you just have to ask directly that question, because people don't consider marijuana to be a drug. You also want to ask if she's been exposed to any type of sexually transmitted infections, because those need to be treated, because they can affect the pregnancy, they can affect the baby. So and it can also affect the delivery, depending on what kind of STI it is. If it's HIV, we need to see if we can get her viral load to 0, right? So we want her taking antiretrovirals. If she's got HSV or herpes, we need her to take Valtrex, because an outbreak at the time of delivery is deadly for a baby. We would want her to deliver by C-section, not vaginally, unless she's on Valtrex, which would cause a suppression. Then she could safely, without an outbreak, deliver a fetus vaginally. We would send her for triple screen, quadruple screen, or alpha fetoprotein. So those are basically screenings for chromosomal abnormalities. They're looking for birth defects. We want to do a physical exam, so we're going to do a head to toe. So we're going to listen to her heart, belly, and lungs. We are going to measure the fundus. We're going to try to listen to her heartbeat. We are going to put her on the monitor. We're doing a lot of teaching. We're also sending for prenatal labs, so we're going to ask for a prenatal panel. And in that prenatal panel, there should be a CBC, because we need to know what her hemoglobin and her hematocrit is. We need to know what her white blood cell count is. We want to know what her platelets are. We want to know what her blood type is. We need to know what her RH status is. So we need to know her rubella. We need to know her hepatitis, her HIV. All of those things need to be looked at. We are going to teach about nutrition, about her caloric intake. We want to teach about what kind of foods to eat, and lots of fluid, and eating green leafy vegetables for like calcium, and taking folic acid, because folic acid also helps with prevent neurotube defects. Taking a prenatal vitamin. We also want to discuss that 25 to 35 pounds for a normal BMI. So for a patient that has a normal BMI, 25 to 35 pounds is what we expect them to gain during the pregnancy. That would be normal. As far as you being the nurse, we're taking care of these patients. You want to talk to them about, like, this preconception counseling starts before they actually get pregnant. So we try to counsel them and get them for genetic testing. If we can, try to get that family history, look at all the risk factors, any screenings or diagnostics we need to send them for, and answer any questions that they might have. But we want to get a physical assessment and get all of the data. Now, at every visit, after the first visit, after we've done all those things for the first visit, every visit after that, we're going to get vital signs, We're going to get a weight. We're going to get a fundal height. We're going to determine what the gestational age is. We're going to get a urine because we want to dip it for protein and ketones. We're going to assess for any swelling in the face, the hands, the lower extremities. We're going to ask if she has any blurred vision, if she has any vaginal bleeding, any leakage of fluid, and if there's fetal movement, if it's appropriate. So at like 20 weeks, they should be feeling fetal movement. But definitely at every visit, vital signs. That is temperature, that's heart rate, that's blood pressure, that's respiratory rate. You can get a pulse ox, like you're going to ask all of those things, or you're going to assess all of those things. And the fundal height, we're measuring from the top of the pubic bone to the top of the fundus to see about how many weeks our patient is.